Welcome to our IVF webinar. It's great to be back with all of you again. And we have another special guest. Hello, Yasmina, how are you feeling tonight? Great to have you here. This is your first webinar with my IVF Fences, so we are really excited to see what you have prepared for us. And of course, we are looking forward to this webinar with you. How are you today? Hope you are all okay.
Fine, thank you. So everything is going well here in the consultation. So happy to be here and to join us for first time.
Yes, exactly. So thank you so much already for agreeing to present this particular topic. As you know, we will talk about recurrent pregnancy loss, which is definitely a tough topic for sure. And Dr. Yasmina will present one of her cases, and of course she will take us through all the steps that were taken, and of course to get that final result, successful result, which is a pregnancy, of course. So we will start with that, but as you know, we will also have some time for your questions. So as always, let me just remind everyone, you can put those questions in the chat section, and Dr. Yasmina will answer them for you right after the presentation. Okay, so don't hesitate, you can ask anything. Remember that we are here just for you, and all of this is anonymous. It's going to be recorded, but of course all of this is anonymous, so feel free to ask anything. Really, it is all about your questions and of course the advice that you can get free of charge, and of course I'm sure that it's going to be useful for you. And let me just add that Dr. Yasmina-Ben-Aicha, I hope I said that correctly, is a gynecologist and of course fertility specialist at Equipo Juana Crespo, located in Valencia and in Spain. And I know that Dr. Yasmina, she's been very, very busy tonight, and she just finished one consultation and decided to join us right now and of course help you out a bit with all of your questions as well. And let me just add that, of course, all of our IVF webinars, this is a project called Success Stories, Real Life Cases. We are focusing on real life cases, patient cases. As you know, those topics that we discuss are different, but of course, this is one goal, the successful outcome. So I'm glad that we are bringing you all of those cases. And as you know, it's always amazing to see what can be done, those little details that sometimes can make a big difference. So that's it from me. I'm Caroline, your host as always. And now, Dr. Yasmina, I believe we can start with your presentation, right?
Yeah, it's perfect. Yeah,
excellent.
Thank you, Caroline,
so much
for the introduction. So it's a pleasure to be here tonight. So it's perfect. Okay, here we can see the slides. I think that, and I am going to check that also. Perfect. So tonight we are going to talk about the recurrent pregnancy loss with a successful case that we are going to check step by step, and then I will be glad to answer all your questions. First of all, let me introduce the case. So here we have a patient, 37 years old. She has had three pregnancies. We are going to check that after that. There were 3 miscarriages, but she was just looking for pregnancy after 4 years with her husband. She has had regular periods, a BMI 20, and she was suffering of dysmenorrhea. As a clinical background, we can just summarize that she has had a subclinical hypothyroidism. That's why she was taking Eutirox, 50 milligrams per day. And related to her husband, a healthy man, 38 years old, BMI 21, and nothing to mention related to the sperm sample. It was a normal sperm, and they were looking for the pregnancy during 4 years. And she has had one pregnancy in 2018. After 18 months of search, it was a spontaneous pregnancy, and it has ended with a miscarriage at 8 weeks of pregnancy. To solve that miscarriage, it was necessary to give her a medication, the misoprostol, in order to just make some uterine contractions and to clean the uterus. Then the second pregnancy, we will talk about it later, but I want to summarize it here. It was in 2019 after the second Ivf treatment, and it has ended with a miscarriage also at 10 weeks of pregnancy. And it was needed also the treatment of misoprostol in order to clean the uterus. And the third pregnancy, it was in 2020. That was the last pregnancy that she has had. And after the second Ivf method also, and it has ended with a miscarriage at 11 weeks of pregnancy. And in that case, it was necessary the misoprostol, the medication to produce contractions, plus a curettage, and after that curettage, a surgical hysteroscopy in order to clean some retained products of conception that there were inside the uterus. So that's the basic situation that we have. We are going to check step by step the background and the previous treatment that this patient had. The first one, it was in January 2019. She has had intrauterine insemination with no result, and they decided to go for an IVF treatment. The first IVF treatment, it was in March 2019. It was a short protocol using only FSH, 225 units, and they obtained 17 eggs. 12 of them, they were mature, 11 of them fertilized, and they decided to vitrify the embryos because there were a suspicion of an intrauterine polyp, and they decided to vitrify one embryo in day 5 and one embryo in day 6. Both of them, there were good embryos, and they decided to perform a hysteroscopy, a surgical hysteroscopy, to remove the polyp that they were just suspecting during the egg stimulation process. 1 month after, they have started to prepare the endometrial preparation, and they had gone for the first embryo transfer with 6 milligrams of estradiol. We have to take into account that the normal dose to prepare a uterus is around 4-6 milligrams, and they transferred one embryo, one blastocyst embryo, and that she was pregnant, and they had a miscarriage at 10 weeks of pregnancy. It was needed the misoprostol in order to clean the uterus. Some couple of months after, they decided to prepare the uterus again and to go for another trial. And they prepared the uterus with the same dose, 6 milligrams of estradiol valerate, and they transferred one embryo, one day. Sorry, there's a mistake. It's a day 6 embryo, and she was pregnant, and the final result, it was a miscarriage at 11 weeks of pregnancy. Here, it was necessary not only the medication to clean the uterus, but also to perform a curettage and a surgical hysteroscopy because there were some remainings inside the uterus, and it was necessary to clean it. And with that procedure, the uterus is suffering a little bit. After that situation, they decided just to wait a little bit till they were just with more energy to go for a second IVF treatment. This time, the stimulation, it was in a short protocol also, 150 units of FSH and 75 units of Menopur. They use the embryoscope, that it's a specific incubator where we can just check the embryos when they are still in the incubator, and the MAX method in order to select the sperm, although the partner had a good sperm sample, but they decided just to go with all the procedures available. And they obtained 7 eggs, 5 of them they were mature, 4 fertilized, and at that time they decided to go for a fresh embryo transfer with a good blastocyst embryo, and they could vitrify another embryo in day 5. And the result, it was a negative result, a negative pregnancy test. They decided to wait some months, and in September 2020, they start another endometrial preparation with 6 milligrams again of Valerate estradiol, and they transferred one day 5 embryo, and they were no pregnancy. So it was just after all this procedure, all this treatment, they were just getting a little bit tired, and they stopped a little bit just the month, and the month after they decided to go for the third IVF treatment. And at that time, they performed a PGTA in order to analyze the embryo and to know the chromosomes in order to check if there were some abnormalities in the chromosomes of the embryo, which is one of the points that we have to check when there's a recurrent miscarriage or a recurrent pregnancy loss. They used a short protocol, 225 of FSH, and also using the embryoscope in order to see the embryos during the development, and the MAX method in order to check and to select the sperm. They obtained 6 embryos, 5 of them they were mature, 4 of them fertilized, and they vitrify, and they could analyze 3 day 5 embryos plus 1 day 6 embryo. And the result after the PGTA, it was that this patient, she has had 3 normal embryos. So at that point, we know that she's able to have normal embryos. It's important to mention that she has had also a normal thrombotic risk profile after checking the implantation failure, some blood tests that it's necessary. We're going to talk about it later, when there are some miscarriages and some recurrent pregnancy loss. Normal karyotype in both members of the couple, and moreover, she had performed some ERA, EMMA, and ALICE tests that they were normal and no problems in that point. So we have a total 4 embryos transferred. 1, it was in fresh, and 3 of them, they were in a substitute cycle using 6 milligrams of estradiol. When she arrived here in our clinic, so we have to check the patient. It was in December 2020. We performed a gynecological checkup. We have done also an ultrasound, and we found a retroversed uterus, a small myoma, which is a subserous myoma, and we were just seeing that the anterior wall, it was more thick than the posterior wall, and a good ovarian reserve with a total of 12 antral follicles. We wanted to go further steps and to study a little bit more the uterus. That's why we decided to ask for an MRI that it was showing that the subendometrium, so the junctional zone in the anterior wall or in the anterior face of the uterus, it was thick compared to the posterior wall. And also we have had a small myoma, and the endometrium line, there were thick also. We wanted to check the activity of the uterus in a mock cycle, in a trial cycle, with 6 milligrams of estradiol, and after the endometrial preparation, in order to see what was the situation before the endometrial preparation in the previous attempts. And we found an endometrium thickness of 12.3 millimeters, the myoma on the fundus, which is what it was not a problem, a retroversed uterus, and adenomyosis in the anterior wall. we decided to perform a diagnostical hysteroscopy in the consultation, and we were able to see that there were a normal aspect in the posterior wall and some inflammatory points like small polyps in the anterior wall, which is the one related more with the adenomyosis and the one who was suffering more in the previous treatments. So the final diagnosis, it was that we have had an endometrial and subendometrial problem in the anterior wall plus adenomyosis. So we can just define the problem as a uterine factor. Here we can check the MRI, okay, just to see in red, we can see the anterior wall, which is just more thick than the posterior wall, and also the junctional zone, which is more irregular, and there's more, it's thicker in the anterior part, which is just giving us the information that there's more fibrosis and some problems in this level. So we decided to arrange a plan for this patient, for this couple that they wanted to get pregnant. And in the plan there are some points, different points. The first point, it was to go for a short protocol using 225 units of FSH, 75 of Menopur, and just we were keeping in doubt to perform the PGTA or not. It will depend on the number, the quality of the embryos, because we were knowing at that time that this couple, they were able to have normal embryos. The second step should be to arrange and to prepare the uterus. We are going to talk about it later with a specific treatment, and to go for an embryo transfer. Just we decided to lower the dose because the endometrium, it was thick, using 6 milligrams, and let's see the results later. I don't want to spoil the end. So we started the protocol in February 2021, the egg stimulation process, with 225 units of FSH and 75 units of Menopur. We decided to go with a dual trigger, which is giving the patient Ovitrel plus decapeptyl. And we obtained 10 eggs, nothing to mention related to the sperm sample. 9 of them, they were mature, 8 of them fertilized, and we decided to vitrify the embryos 4 day 5 and 2 day 6 because it's necessary to prepare the uterus and we cannot go for a fresh embryo transfer, and not to perform a PGTA. Why? Because we were not sure if some of the embryos, they will reach the blastocyst stage, because they were some medium qualities in day 3, and then so they were a change, and we were just quite sure that she has had normal embryos. So we decided to freeze all the embryos that they reach with no PGTA. On April 2021, we started the uterine preparation. The first step, the patient, she undergo for hysteroscopy, a surgical hysteroscopy, in order to perform a metroplasty to remove some points of fibrosis, to prepare the uterus, to revascularize the uterus. We were finding some moderate fibrosis and the anterior wall a little bit more affected. And after the hysteroscopy, we gave her a treatment in order to prepare the uterus with also estradiol valerate and also the decapeptyl, quarterly decapeptyl, and 1 cycle of Femara in order to decrease the adenomyosis, that it was more concentrated on the anterior wall. After this first preparation of the uterus, we decided to go for an endometrial preparation. That was in June 2021. We started with a substitute cycle with 3 milligrams of estradiol valerate. We performed a scan in the day 8 after starting the treatment, and we found the endometrium thickness, it was 7.2, but the limitation, it was quite bad. and the patient was suffering also flashes. Still, a remaining effect of the decapeptyl. We performed a diagnostical hysteroscopy in the consultation, and we found some isolated micropolyps in general in the anterior and posterior wall. And we decided to cancel this endometrial preparation, to give some antibiotics and probiotics for treating her. And after amends, after a period, at the end of the same month, we started another endometrial preparation. With a substitute cycle, we decided to increase a little bit the dose, 4 milligram of estradiol valerate with a previous GnRH antagonist. That's a difference on the preparation. We performed also a scan on the 9th day after starting the treatment, and we were checking, and we found an endometrium, a good endometrium, triple line, 6.7 millimeters, that it was quite good. We decided to go further steps and to perform the embryo transfer, but we decided to do a previous ultrasound the morning. So normally the embryo transfers, they are during the afternoon, evening time. So the same morning, the same day of the embryo transfer, an ultrasound to check that everything was fine. And we found an endometrium line 8.3 millimeters with good appearance, and we go ahead with the embryo transfer. We transferred one embryo, day 5, with no complications, and the patient was just, we gave her heparin after the transfer till the pregnancy test. And unfortunately, the result, the pregnancy test, was negative. We decided to discuss the case, to analyze step by step all the points. And we said, well, if the substitute cycle is not working, let's go for a natural cycle and to use more embryos, because this patient has normal embryos, so let's go for it. And in July 2021, we decided to change the strategical organization and to go for a natural cycle. We checked her after in this situation with a natural cycle, and we found an endometrium thickness that it was 11 millimeters and a dominant follicle of 15 millimeters. It was just looking beautiful, and we decided to go ahead. As a medication, she was taking some vitamins, fertibiotic, and the Euthyrox because of her hypothyroidism background. We performed also a previous ultrasound the morning before the embryo transfer, and we saw an endometrium thickness of 8 millimeters with a good looking, and we decided to transfer 2 embryos, day 5, no complications, and the patient was also taking the heparin after the embryo transfer till the day of the pregnancy test. And the result after this endometrial preparation, it was positive. We are just looking for the patient. She is in a good situation. It's a pregnancy around 13. The moment that I was just preparing the slides, 13-14 weeks, and till now the situation and the clinical case, it's going good. So just to summarize some of the points that I have been talking about them, I wanted to put it here, the information that is from the guideline of the European Society of Medical Reproduction, and the recurrent pregnancy loss is defined when we have 2 or more pregnancies, so when there's 2 or more miscarriages. It's important to know that the pregnancy loss increases after 40 years old, and there are some points for obviously some toxics like the tobacco, the alcohol, the drugs, but also, and sometimes we don't pay attention for that, the maternal obesity. It could play a negative impact in that situation. It was not the case in our patient, but it's important to mention that it could just have a point to check in that part. And for a conclusion, related, I think that we are going to check it with the questions, but some complementary exams, when it's needed, when it's not. The recommendation of the ESRA in the last guideline that it was published, they recommend when we have recurrent pregnancy loss to go for to check the antiphospholipid antibodies, to check also the implantation failure, the anticardiolipin and the beta-2 glycoprotein, also the antinuclear antibodies, and to check also the thyroid in order to see if it's necessary to levelize or stabilize, to make some treatment against that. And they do not recommend the HLA determination, neither the cytokine testing, neither the NCAL, the natural killer cells. So that's the summary on that point. And just I am looking for the questions that maybe you will have had. Some points to clarify.
Thank you so much indeed for your presentation and that clinical case that always brings hope, and especially that it's been definitely a tough one. Thank you so much for bringing
You're welcome. Thank you.
I believe it has been helpful for you and to make you maybe think about some other aspects as well. And right now, as you know, it is time for your questions, so don't hesitate. Just go ahead, type those in, and Dr. Yasmina is right here to support you, to help you out with all of your questions. So let's get going with those, okay? There are like 2 questions right now, but I do see that people are typing in, so I'm sure there will be some more. So yeah, let's go ahead with those. Melissa has one of the first questions. How do you treat hormonal imbalance that can cause miscarriage?
Okay, I would like just to know hormonal, how we define, so hormonal imbalance, so related to the thyroid or related to the ovaries, because sometimes, for example, the thyroid is related. There are some treatment that we can give to the thyroid, like the Eutirox. There are also some hormonal imbalance when we have some disorders in the FSH, LH. I don't know in which way it was this question asked, because when we have a polycystic ovary also, we can have some hormonal imbalance. And then so we have to arranging it during the ovarian stimulation. So maybe Elisa can just give me more information related to that, and I can just
Yes, Elisa, we can add some more, but just to make sure, you know, what are the most common ones? I guess thyroid is probably one of those, right? Okay.
And also, yeah, we work together with the endocrinologist in order some initial problems with the thyroid, we can just work with them and just give medication. But normally we try to work in a multidisciplinary way in order to arrange it and to make a good treatment for the patient.
Okay, sure. Elisa, if you have something else that you would like to get some more information, of course, go ahead, type us in. But thank you so much, Dr. Yasmina, for explaining this as well. And let's have a look, okay? Let's have a look at the next one. So how is adenomyosis best diagnosed? Is a laparoscopy useful?
Okay, so we have to take into account what's the adenomyosis. The adenomyosis, it's like that there are some inflammation, some points of endometriosis inside the uterus, inside the walls, that is just giving inflammation, some bad preparation of the uterus. Mostly of them we can check it with an ultrasound, that it could be a good way to see it. But sometimes if this adenomyosis it's in a low percentage, sometimes we have to make just some mock cycles, some trials, give some medication in order to see how the uterus is responding when the estrogens are really high. So normally the most effective way and simple way it's just to go for an ultrasound, a pelvic ultrasound. There are some times that we ask also for an MRI in some specific points of the cycle and to check that. With a laparoscopy, we are going to be able to check the ovaries, the fallopian tubes, but that it will not give us information related to the adenomyosis.
So much, and I do believe it has been helpful for you as well. Okay, and of course, there's a thank you from the patient for you right here. And let me go to the next question from Elisa. Okay, there is a follow-up from her. Let me have a look. So I was diagnosed with hypothyroidism. My TSH is 4. What is a normal level? If you can.
Okay. We have to know that in a general medical background, that TSH is normal till 4. But when we are looking for pregnancy, the recommendation, and we like to have a TSH lower than 2.5. So that's why even if it's in 3, your your GP will tell you, no, that's fine, it's a good level. But when we look for pregnancy, in order to have a good behavior and mostly taking into account for a healthy first trimester of the pregnancy, the good level is to have it lower than 2.5. And if not, so we recommend or to check with your endocrinologist or to start with a low medication and to perform a blood test 4 weeks later.
So much, Elisa, for that follow-up. Okay, I do believe now you feel more confident right now. Thanks so much also for your comment, of course, Dr. Yasmina. Let's have a look. Okay, all is clear, and Elisa, of course, says thanks and understood.
It's a pleasure.
Thank you so much. And let's have a look. Katya has another question for you. So do you have any recommendations after having 2 miscarriages and now getting ready for a donor embryo cycle? I do have Hashimoto.
Okay. In that situation, it's important to levelize and to check the Hashimoto. So to double check with the endocrinologist that there's nothing else to add or something on the treatment to check before in order to control as much as possible the body situation. If we have changed the eggs already and we are not going to use the own eggs when we go for an embryo transfer and there's no male problem, so that we can just avoid the PGTA, it will depend on the case, okay? But in general, we can just give this information to check. So it depends on the reason of the previous miscarriages. That's why it's really important to know the case and to know the reason why. For example, if these 2 miscarriages there were for an abnormal embryo, I would have more, I would be more, how to say that, I will be more confident to go just with embryo donor cycle with no other treatments or no other points to check. If the embryos, they were normal, so then we have to look for further steps and to check, for example, the uterus, if there were something that it could be the reason of these miscarriages. So, or we have the embryo, or we have the uterus, or we have some endocrinological disorders that we have to check, or there are some unknown cases, but we like to know always the reason why.
Again, that's another good advice, of course. So thanks a lot for explaining, and thank you for your question as well. And again, as you can see, a question and answer, and of course, a thank you from Katya. Okay, and let's have a look. We are waiting for some more questions. So remember that we are here to support you, to give you some answers, and you can use this time and ask Dr. Yasmina anything. If not, of course, we will be finishing. But as always, remember that this is, of course, a webinar when you can get some advice, but there is always a possibility for you to get in touch directly with Dr. Yasmina and her team at Equipo Juana Crespo. And I am more than sure that they will be able to help you out even more. All the doctors will need all the details, so I'm sure that it's going to be much more helpful. But this again, this is the time for you to use that. You can simply just even sometimes I know you'd like to get some other opinions, etc. So this is your chance to get that. So go ahead, type those in. And let me have a look, of course. Okay, yeah, another question is right here. Okay, does DNA fragmentation in sperm take part in repeated pregnancy loss?
I was expecting something like that, so it was weird that it was not there.
It's right here then.
There are some discussions, right? Because the sperm is playing a part, and nowadays there are some extra tests that we don't know exactly how to use related to the DNA fragmentation. There are some studies that they say that they play a part. Some of them, they are not giving a lot of importance to that factor. So there's a discussion, okay? Here, so in our clinic, we pay more attention to the egg and to the uterine factor. And so sometimes when there are a really bad sperm, so we check further points, but we don't pay a lot of importance to the DNA fragmentation, because we have to take into account that in the sperm, most of the times there are millions of spermatozoa, and we have the experience of the biologist who is able to check the perfect spermatozoa in order to fertilize one by one the eggs. So, and the spermatozoa is just giving the chromosomical information, and also a really good egg could just improve just a medium or low sperm sample. So I would say that, yeah, it's in discussing that step. And there are some groups that they say that here, and there are some other groups that they take into account other points, and they say that it's not worth, and they are not paying a lot of importance to that point.
Thank you so much. Of course, thank you, Elisa, for bringing this question. Although this is something that still we need some more details. Again, this is again one of those fields where we need some more data to be able to answer properly and give you a yes or no, right? So there are still so many things that we still need to wait for. So
Sure.
This is one of those. Thank you so much indeed for bringing this. This is always a good to discuss that. Okay, and Elisa has one more question, possibly our final question. So if you've got any more, you know what to do. And the question is, have you ever had a patient with unexplained infertility and no doctor knew what was caused?
Well, that's a difficult question. So
It is true.
Yeah, I can. So there's some percentage of unexplained infertility. Personally, and here in the clinic, we always want to know the cause, because it's not a bad luck. We like to know why. As almost all the doctors, I guess, we like to know the reason, to analyze what's, and mostly, so in all the cases, we find the reason. I can say so that always we can find a fault or some reason for that, or we think that it's the cause. So, and not yet. Maybe during my career, I will find more difficult cases or some different, because each case and each couple, it's completely different. You cannot compare situations. But personally, I try always to find the reason and to just improve that situation in order to get a good result.
Amazing. Thank you so much for yes, another interesting question indeed. Okay, and Sebastian has another one. Okay, let's have a look. Another question that it is interesting. So, can a decreased long-term motility of the sperm, 0% motile sperm after 24 hours, affect the embryo quality and the risk of miscarriage?
Can a decreased long-term mobility on the sperm affect the embryo quality? So that's a specific test on the sperm. So as I said previously, the sperm, it plays a part. The most important thing on the sperm, so it's the appearance and the specific selection on that. The important thing also, so even when we have no mobility in the sperm, with the ICSI method, when we perform the ICSI method, it solves that problem. So the mobility, it's only an information that gives us that the sperm is not able to reach the fallopian tube and to reach the egg in that situation. But when we go for a testicle biopsy, for example, we obtain some no mobility spermatozoa. So it's only to give the chromosomical information. And till now, so as I can know, so there's no affectation in that point. So
okay. Understood. Again, thank you so much indeed for your interesting question, as I've mentioned, and for answering this one as well. As I mentioned, might have been our final question. So if you've got any left, do it now. Go ahead, type those in. If not, as I've mentioned before, there is always a possibility for you to get in touch with Dr. Yasmina and her team at Equipo Juana Crespo. And if you've been able to join our previous webinars, there are I guess all the doctors that you've been able to see, they will be happy to help you out. I am sure of it. This is a great team behind Equipo Juana Crespo, so I'm sure they will be happy to help you, and I'm sure they will do a thorough job as well. So we will be finishing for tonight. Dr. Yasmina, thank you so much for joining our webinar tonight, for your time. And of course, you know, this is your first webinar with us, but I do hope this is our first one and not the last one. So I'm already looking forward to some more webinars with you. It's been a pleasure to cooperate. I do believe you found this useful as well. So yeah, that is it really. But before we finish, Dr. Yasmina, as always, is there anything else you would like to add?
Well, so I think that we have checked and we have discussed some of the points. So as a general idea, we have to check the case, and in a recurrent pregnancy loss, so we have to check the embryo, we have to check the egg, we have to check the general health of the lady, of the patient. And so we have to just don't forget that that's a global analysis, so not to give a general conclusion. So each case is different, and we have to personalize the situation, and we cannot compare this patient with the patient that is in the next consultation. So it's important to have a personalized a study of the case, and to know which patient it's necessary to go for this treatment or for another one.
Perfectly summarized. So thank you so much indeed. And as you know, this has been recorded. So if anyone missed any parts, you will be able to watch this again on myivfmsys.com. It will be available tomorrow. But if you go to our YouTube channel, the video will be there as well with all the previous webinars, of course, as well. And let me just add that there are almost 400 webinars so far. So plenty of topics, plenty of questions that already have been answered. So, and of course, on our website, there is even transcription of those Q&A sessions. So sometimes if you don't feel like watching, you can always have a look and read it. And I'm sure you will find it useful. So I can only encourage you to do that. And as you know, we will be back with some more success stories tomorrow at 7 p.m. UK time. There is another topic, and there is another doctor that will be discussing and presenting, of course, success stories. So I do hope that you will be able to join us and have some questions as well. Thank you so much, Dr. Yasmina. It has been a pleasure, as I've mentioned. Thank you so much. Have a lovely evening, everyone. And well, see you tomorrow then, okay? Thank you so much. Take care. Bye-bye.
Thank you, Caroline. It's a pleasure.
Thank you. Bye-bye.